Chih-Cheng Wu MD, and all of our speakers today, Dr. New Yang Hsieh MD, as an attending physician, Division of Cardiology, Department of Internal Medicine, NTUH-RSCM branch, and our speaker from Dr. Cipto Mangunkusumo. Welcome and good morning, Dr. Eka Ginanjar, as an head of Integrated Cardiovascular Service, Cipto Mangunkusumo Hospital, and all of our delegate participants from in the world, from Indonesia or from Taiwan, this webinar. Good morning and very welcome to the Excellencies, our program today. Second episode, NTUH Cipto Mangunkusumo Hospital joint webinar by tema Cardiovascular Continuum of Care in COVID-19 Pandemic, Saturday, 15 August 2020. Dears, ladies and gentlemen, thank you for PhD as a Human Resource Education and Research Director Cipto Mangunkusumo Hospital to present her opening remarks. Please welcome Dr. Trimartani. The time is yours.
Thank you, Ms. Yuni. First of all, I would like to apologize that I'm wearing a mask because I'm at home actually. So, Assalamualaikum warahmatullahi wabarakatuh. Good morning to all of us. First of all, I'd like to extend a warm appreciation to NTUH-RSCM branch faculties. Dr. Chih-Cheng Wu as the Director of Cardiovascular Center, National University Hospital, Chih-Cheng branch. Dr. Hsieh as the Attending Physician, Division of Cardiology, Department of Internal Medicine. Welcome to NTUH-RSCM joint webinar, our second episode. Our topic today will be Cardiovascular Continuum of Care in COVID-19 Pandemic. As we know, we're fully aware that now the changing rapidly. Early this year, COVID-19 has caused impeccable to many aspects of our life, including the healthcare system. Cardiovascular healthcare system is no exception. In Cipto Mangunkusumo General Hospital, we face many challenges. In cardiovascular, patient visit decrease, clinical slightly modified, for example, ST elevation myocardial infarctory treatment modified from primary percutaneous coronary intervention to fibrinolytic therapy. Not to mention, cardiosurgery was also halted. We believe that challenges are also faced by National Taiwan University Hsieh branch colleagues as well. But the science of COVID-19 are evolving. Pathophysiology, diagnostic method, management, prevention strategy are extensively studied worldwide. As the knowledge of COVID-19 is expanding, the cardiovascular services is expected to grow even more, especially in new norm era. In concordance with the situation, the NTUH and RSCM joint webinar is arranged to share knowledge and experience from both institutions from a better management of cardiovascular service. Our collaboration has been established since 2014, and this year has been our great pleasure to work with the NTUH branch. We acknowledge our excellent expertise in this field, and we hope both our institution and participants will gain useful even further in the next. We apologize, and we hope this webinar will be a fruit for all of us.
Very much for your opening remarks, Dr. Trimartani. Ladies and gentlemen, moving to our main agenda is scientific session. This session will be led or moderated by Dr. Chih-Cheng Wu, MD. He is as a director of Cardiovascular Center in NTUH branch, and also he was graduate in 1994 at Medical College of National Yang-Ming University. He very interested at research by many topics like vascular biology, cardiovascular clinical epidemiology, hemodialysis vascular access intervention, and hemodialysis vascular access vascular biology. Please welcome Dr. Chih-Cheng Wu, MD. The session is yours.
From Taiwan, and the second one is from Chih-Cheng. I will introduce the speaker of the first talk from Taiwan. The speaker of the first talk is Dr. Hsieh. Dr. Hsieh is the director of cardiology division of our hospital and faculty of and faculty of medical college, Taiwan University Hospital. Dr. Hsieh has visited Chipto last year, and he's now in charge of the COVID-19 coping program in our cardiovascular center. Let's welcome Dr. Hsieh for sharing the Hsinchu experience in COVID-19 program.
Okay, thank you. May I change to my slide? Thank you, Dr. Wu and Dr. Ko and the friends in Indonesia. Okay. I have my slide on. This January. Actually, I have limited experience in care options. And in 2019, I have the fortune to visit Indonesia. And today I'm wearing the same tie, the same suit to perform this talk to you. Nice to meet you. And to be honest, in Taiwan, we only have 481 identified cases. And in recent 2 months, actually, in my team, we have 0 cases. And these are the protocols initiated in Hsinchu. Mainly our focus on preventive medicine. So before hospital, we have a telemedicine at the hospital and in the classroom and the nationwide STEMI service. I will report our experience here. So For patients who have been isolated in home or in the isolation hotel, we have our telemedicine program provided by cardiologists. And in the emergency department, we have separate patient flow by tents and the doors controls. And then we have our ICU control. Okay.
Freezing.
And can you read our slide?
Yes.
Okay. Thank you. I shall proceed. And then as for confirmation of the travel history, in the hospital entrance hall, we have linked universal identification card to the airport records, so we can 100% sure whether this patient comes back from abroad. And in our critical care ward, we have modification and adjustment made to increase the numbers of isolation beds, especially negative pressure beds. And in the ward, we have personnel entrance control, which every patient's family must have their name and a national ID registration at the entrance to the ward area while accompanying their family. And for my classroom, the patient transfer route isolation. After re-evaluation, we think it is impossible to change the route due to hardware and structural reasons. So we have temporal time restriction and the protection as needed. And then for personal protection gears training, we have posters. We have repeated on-site training with supervision in the cath lab, and we have videos recorded. Special lecture delivered by our critical care chest medicine staff, and they talk about the basic variations of the COVID-19 patients. And in our CCU, we have rearrangements, which was facilitated by our head nurse and coordinated by our ID men to provide a basic isolation protection. And we also have drills for resource allocation and urgent isolation scenario simulation provided by our critical care center, which was joined by physicians from different specialties, including cardiologists, chest men, ID men, and the nurses and the respiratory staffs. And these drills provide detailed allocation of our resource because we have limited bed number with specialized negative pressure protocol. May I have my slide back? Okay. 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 Can you still hear us?
Yes.
Yes.
Okay. So I'm going to talk. Thank you. And then I will talk about our split team working schedule. We have this split team working schedule test run between March to April. I separate my team, the whole team, into A team and B team. They will switch on a 2-week period, and the A team, B team will be separated by the working floors. As you can see, Dr. Chih-Cheng Wu is here, and then among him, I'm also in the A team. And during this 2-week period, the A team will be mainly working in the outpatient departments and providing emergent consult to the ER cases. And the B team will be working in the classroom and the echo room. And after 2 weeks period, the A team and the B team will switch. And why we try to do this split team run working schedule? Because after reviewing a webinar provided by European doctors, we want to provide a full service while not decreasing our elective cases. before the real outbreak. So this split team method was mainly formulated to provide care before the outbreak. And once the outbreak starts in the first week, I can preserve half of my team providing cardiovascular care to the Hsinchu. And after the outbreak, they preserve their human staff resource. They only allow 3 interventional cardiologists and 2 cardiac surgeons to work in the hospital. And mainly, most of their doctors will be involved in the care of COVID-19. So their report let us learn and formulate our strategy. So we have our separate team manner. And in Hsinchu, Taiwan protocol, mainly we adopt and then modify our protocol of STEMI from Germany. For STEMI, we consider the full personal protection is safe with adequate personal training. We will proceed with primary PCI. And this is
Would you allow us to move on the next talk? I will introduce Dr. Ginanjar from Chih-Cheng Hospital. Dr. Ginanjar is the head of Integrated Cardiovascular Service in Chih-Cheng Hospital and also faculty of medicine in University of Indonesia. He is also a master of hospital administration. His topic today is cardiovascular service in new normal era, the RSCM experience. Let's welcome Dr. Ginanjar.
Thank you, Prof. Nice introductions. Good morning, everybody. Assalamualaikum.
所以他们在这边，
对，他们的画面是这样。
声音有，所以他们可以做 troubleshoot。他们抱歉，抱歉。
Hello, can you hear me? Profesor Wu? Dokter ya, boleh kelihatan sekarang? Respon. Profesor Wu, Profesor Hsieh.
Can hear you.
Okay, so we can start again. Sorry for inconvenience because of technical problems. So I will okay. Next slide. Okay. Professor Wu, Professor Hsieh, because of the participants, a lot from Indonesia, and then they come from a period of hospital in all Indonesian. So we will start from cardiovascular damage. This is my outline. So please, for me, I will start from a bit about the pathogenesis and then the guidelines for the cardiovascular care, and then we will talk about integrated cardiovascular services and RSCM, and then we see what RSCM experience cardiovascular service in COVID-19 era. Okay, I will start in the first topics. Cardiovascular damage, we have known that this coronavirus COVID-19 viruses that can cause disease in animals or humans have previously caused two major outbreaks. SARS, we know, in Hong Kong, and I don't know, maybe in Taiwan in 2003, and MERS in more than 60 years. Sorry, can you hear me, Prof? Have a problem in connections. Maybe because of yesterday we have storm in Jakarta. Maybe it caused this failure of connections. Sorry for this inconvenience. Saya ngomong juga kedengaran kali ya. Now, can you hear me, Prof?
Silahkan, Dr. Eka.
Okay, so we'll continue.
Yes.
Thank you, Dr. Ria. So you know the cardiovascular disease, including hypertension, is the underlying conditions among adults hospitalized with COVID-19, especially in people or patients more than 65 years old. And in World Methods Info, we know that more than around 13.2% if we look a bit about pathophysiology, we know H2, which is expressed in lungs, heart, and vessels, is a key member of the renin-angiotensin system, atau well known as renin-angiotensin systems, RAS systems, important in the pathophysiology of cardiovascular diseases. Cardiovascular disease associated with COVID-19 likely involves dysregulation of RAS S2 system due to SARS-CoV-2 infection and due to comorbidities such as hypertension. CVD, cardiovascular disease, may be secondary to acute lung injury, which leads to increased cardiac workload, potentially problematic in patients with pre-existing heart failure. Cytokine release storms originating from imbalance of T-cell activation with dysregulated release of interleukin-6, interleukin-17, and other cytokines may contribute to CVD in COVID-19. And we know interleukin-6 targeting is being tested therapeutically. And then some cases in Indonesia with anti-interleukin-6 have a successful story to resolve this problem. Immune system activation along with immunometabolism alterations may result in plaque instability, contributing to the development of acute coronary events. So, virus SARS-CoV-2 enter upper respiratory tract, cause local replication in upper respiratory tract epithelial cells, and then it can spread to lower respiratory tract. And the spike protein, the S protein in the virus, cause virus binds to S2, angiotensin converting enzyme 2 receptor in the host cell. Unfortunately, H2 receptor can also be found in intestines, kidney, blood vessel, and other organs. So this mechanism continues by genome replication and translation from RNA virus, and this replication and transcription cause the multiplication of the virus. So the viral load will be increased, and the cells of the host will be destroyed, and then it causes also the inflammation reaction. So this is the cartoons. Yeah, cytokine storms can happen after the infection and after the replication of the virus, and then it causes the systemic effects to the humans, to the patients, and then it can cause the mortality. So if we focus on the cardiovascular problems, after infected the lungs, so the virus can go to myocardial site, and then it can cause the myocardial damage. And this myocardial damage can cause the fulminal myocarditis, and also it can cause the arrhythmia and directly cause heart failure. And this situation can expose and start the cytokine storms. Besides that, this virus also can destroy the regulation of the coronary artery, vascular vessel, and also the microvessel, and it can cause the plaque instability and rupture, and acute coronary syndrome can happen. So this virus can cause myocardial damage, myocarditis, and also can cause the coronary syndrome. Both of these conditions can cause so I try to explore these three guidelines from ECC, GACC, and ESC, and to see briefly how the guideline states about the cardiovascular care in the COVID-19 pandemic. All guidelines said yes, the cardiovascular complications and cardiovascular persistence along with comorbidity can make the mortality become higher among of cardiovascular disease. The other factors like cardiovascular disease, immune activations, shock, Ya,
masih ya, Dr. Eka. Dr. Eka masih hilang timbul.
Hello, we are still here.
Yeah. Can you hear me?
Yes.
Yeah.
Okay. I think Dr. Ek, our technician, is still working on our. I think it's the connection. I think the connection is not stable yet. Maybe I can ask a few questions to the first speaker.
Yes, please.
Ya,
boleh mendengar saya, Dok?
Yes.
udah siap dan udah ini.
Can you hear me, Professor Wu?
Okay.
Yes, we can hear you.
Okay, Dr. Eka would like to continue.
Yes, Dr.
Lanjut
Ya.
aja langsung, Dr. Eka.
Ya, terima kasih, Dok. Maaf nih koneksinya sepertinya masalah. Professor
Apa-apa,
Wu,
ya.
Professor Hsieh, sorry for inconvenience, and I will continue my slides. So we see in the guidelines for healthcare workers and health system regarding COVID-19 and CVD. So as a providers, we use e-visiting, telehealth, or telemedicine for triage and then patient management. And adherence to guidelines for optimal use of PPE. So this PPE in Indonesia, maybe in Taiwan, you can share of us how we use this PPE because maybe the guidelines different from local, and every country, every states, it different depend on the situation of this the area. So we as health professionals have to self-reporting symptoms if present and halting the rule as a provider in case symptoms arise, and limit elective procedures. For example, echocardiography, cardiac catheterizations, if not urgent or emergence. In health systems, in the hospital point of view, providing and expanding the knowledge and infrastructure for telemedicine is very important to make the health services happen without we contacted with patients. Preparing sufficient PPE for patient families and healthcare personnel. Improving patients and public education regarding indications for quarantine versus hospital presentations. Improve testing availability so appropriate containments can be achieved, especially in our for our staff as medical doctors or the administrative or non-medical staff in the hospital. So we have to we can make proper donations, and then we can prevent the contact, the spread of the virus in our hospital. So to minimizing COVID-19 exposure, guidelines ACC said that for cardiovascular procedure, we have to minimize staffing in urgent or emergency cases, optimize medications, and reschedule elective procedures. And then we use negative pressure catheterization labs. Yeah, Prof. Hsieh already mentions how you have to setting again the cath labs, and then I will in the back will in the next slide will share about our experience to sharing or to setting resetting our cath labs. And for also for cardiac critical care, we have to use appropriate PPE, and for echocardiography, outpatient, inpatient, and cardiology teaching service, we have to modifies the how we use or we do our daily activity. Overall goal is to provide high quality care for patients with cardiovascular diseases while minimizing infection risk to cardiovascular healthcare workers. This is for importance, general consideration for COVID-19 disease. So this ACC guidelines divided to 4 kind of patients or conditions. Number 1 is for patient with COVID-19 negative and no prior CVD. So it is only general prevention like hands washings, clean and disinfected, avoid close contact, use mask, and so on. So for the COVID-19 positive patients with non-prior CVD, we have to consider cardiovascular sequelae like myocarditis, heart failures, as I mentioned before. How about 2 patients with COVID negative but have a prior cardiovascular disease? So they have to aware about the risk to get infections and the cardiovascular risk stratifications. And then we have to do minimum contact to these patients. We have to use telemedicine, self-remote monitoring, and prioritizing high-risk visits and procedures. So we have to see the which patient have to come to the hospital, which patient can stay at home, and then self-remote monitoring, and then see the doctors by the system, by telemedicine. And the last is how the patient positive COVID-19 patient with prior CVD disease. So we have to heighten awareness. Yeah, we have to see the cardiovascular sequelae, and then more closer monitoring as worse prognosis, and we have to aware about cardiovascular medication interaction and toxicities. This is ESC said about the PPA. We believe each country, local, different state, different hospital have a different guidelines about the PPE. But the principle is same. We have to separate as based on the risk. As ESC, WHO use 3 levels of protection: level 1, level 2, and level 3. So we follow our local guidelines, depend on our conditions. And for non-invasive imaging, like I said before, that we have to choose which one have to do in these conditions, or we can do it later on, 3 months or after this pandemic have ended. And for invasive procedures, as we know, we have to divide this procedure as emergency, urgent, lower priority, and elective priority. If it is emergency, like STEMI, non-STEMI with unstable conditions, cardiogenic shocks, and so on, we have to do it now, but we have to consider about the procedures. We have to use the proper PPA and so on. For the urgence, like a non-STEMI, unstable angina, left main PCI, and so on, we can perform with more proper preparations within a days. And then for lower priority or elective patients, we can do it later on, within less than 3 months or more than 3 months, or after this disaster end. And this is for invasive procedures. And how about for acute coronary syndrome? For non-STEMI SCS, we know we have to stratify patient with very high risk, intermediate risk, and low risk. For patient, very high risk patient, we have to do as a STEMI pathway. In our hospital, we have called STEMI, but we have to change, or we have to think about do it the procedures with all the preparations. And for high-risk patients, intermediate patient, and low-risk patient, we have to test for the SARS-CoV-2. If positive, transfer to COVID-19 equipped hospital. If the hospital cannot do it, but in Cipto we have all the preparations. We have different zones, and then we have a special place to treat the patients, so we can do it in our hospital. Separate with the non-COVID patients. And for STEMI patients, we do the STEMI pathway, or in our hospital we call it COD STEMI. But the problem is we have to consider about the screening. The patients with the symptoms similar with the COVID-19, all the patients come with chest pain, difficulty in breathing. We have to consider to separate it. This is prove it. This is COVID-19 patient or not COVID-19 patient. If the time to get it more than 60 minutes, so we need to do fibrinolysis. So in our center, this is our local guidelines, similar with ESC. Yeah, this is our local guidelines. So we have to try to make sure that this have to test for COVID-19. If it is positive, so we have to do it in the proper PPE. But if it is negative, so we can do it more easy. This is our local guiding for non-STEMI and STEMI. So we suggest to do the fibrinolytic first. Then if the fibrinolysis we cannot do a fibrinolysis because of contraindication, so we do the STEMI protocol. Next, a bit about our center and RSCM. This is our Cipto Mangunkusumo Hospital, the oldest, biggest general hospital. All the diseases come to our hospital as a national referral center. So the cardiovascular service is the one of outlet of Cipto Mangunkusumo. An integrated cardiovascular center established in 2003, and it is the first integrated cardiovascular services center in General Hospital of Cipto. We built it in 4 foundations: the pediatric department, internal medicine department, anesthesiology department, and surgical departments. We built it as a center of excellence, one-stop cardiovascular services, as a center of education center, research center, and service centers. Then the most important is this is the integrated part of Rumah Sakit Cipto Mangunkusumo, Cipto Mangunkusumo General Hospital. Then our vision is creating infinite experience in cardiovascular center of excellence with the mission seamless, best performance, best teaching and research centers, best value to works. This is our place. This is Cipto Mangunkusumo Hospital, and then this is integrated cardiovascular centers. Our hospital is in the heart, the center of the heart of Jakarta city. So you can see in the back is the city of Jakarta, and then our hospital is in the center of the city. So our PJT or integrated cardiovascular center have 3 cath labs, 1 dedicated negative pressures cath labs to be. I said to be because we still setting it, and 24/7 operational, and then well-trained nurse, and we believe we have a fast response time, especially for acute coronary syndrome patients. And then we are integrated cardiovascular center, but not only for the cardiovascular disease only. a lot of procedures, including DSA, for neurology and neurosurgery, and radiology, vascular medicines, and so on, do the procedure in our center. And we have electrophysiology study as well, and our center have established the EP teams, that do a lot of procedures of electrophysiology studies. This is the situation. We do electrophysiology studies in our cath labs, and coronary angiography. We have a lot of modalities to do the procedures, and then this is our situation of cath labs, with the color of cath labs, pinks, yellow, blue, and purple. And also for pediatric cardiology, we do a lot of procedures, transcatheter closure of ASD, VSD, and PDA. And how about the open heart surgery? Same as your center, we do the CABG, valve repair, VSD, SD closure, TOF correction, and arterial switch surgery, and all the procedures, adults and pediatrics procedures. This is our situation of our OT, cardiac OT. This is the OT. We do perform the OT before pandemic. This is the photo is before pandemics. And next slide, I will show you how we deal with the pandemics with our service. We have 9-bed cardiac ICU, 7-bed of Hsieh high care unit cardiac, and then we have 10 beds ICCU, intensive coronary care unit. This is our cardiac ICU, and then this is our VVIP ward. So we accept the patients, VVIP patients in Kencana. Kencana is our outlets of private patients with very great service and then great room. And also we serve publics. This is our public patients. Very lot of patients in our service, and then we do it as our responsibility as the government, as a government hospital, public hospital. This is our consultation and rooms, and this is our echo lab, and this is our pharmacy, and then we use queue systems, and this is our rehabilitation center. Next. Okay, so that is about integrated cardiovascular center. Now I go to cardiovascular services in COVID-19 era, experience RSCM. So we have a problem in the beginning of this pandemic. Our patients is reducing because all patients is afraid to come to hospital. Our chronic patients, our active patients is afraid to go to the hospital. This is the condition of catheterization and interventions in January to July 2020. And this is cardiovascular surgery rooms also decreasing, but in June we already try to increase a bit, little by little. So we do a lot of things to prevent the infection transmissions. Of course, we do the general precautions. We do hands washing, face mask usage. Every patient, every staff, every doctor have to use mask. So if you don't use mask, so we don't let you come in. Cough etiquette, standard personal protective equipment, PPE, we use in every single procedures with very tight regulations. And then we apply social distancing and patient screening by body temperature checks and anamnesis. And we limit elevator capacities and arrange distancings. arrange seating distance in waiting area by giving an empty seat between each persons, using plastic barrier between admission staff and visitors. So we also limit patient companions and visitors. Yeah, during this pandemics, we not allowed patients to the visitors or patient companion more than one person for one patient. So and then no visitor for the patients, and limit health care workers numbers in service units, touchless access, and personalized cutlery and prior equipments, schedule visit by online registrations, general cleaning in public area and procedures rooms. We also deactivate any cardiac rehabilitation and club activity. Yeah, before this, every morning in our centers, we our patients, yeah, healthy patients, come to our center to do the club activity, do exercise together, and then chit chat every morning to motivate each other. But currently, we stop all the activity. So all the patients just contacted with e-consultations, telemedicine, and so on. So we suspend several procedures, and then suspend heart disease services for COVID-19 patient, because for the open heart surgery, we don't have facility to do the open surgery for patient COVID-19. But for cath lab, we still do it, because we have we can modify our cath lab to do the procedures. Echo lab, we do we use barrier, and then we do all patient to do procedures with rapid test. These some pictures. You can see all the regulations we put here, and then we strictly make all people have to use masks, and then washing the hands and hand washing, and do all the protocols tightly. This is our situation in front office, and then we use the social distancing. We make people not sit side by side, but we have to avoid some place to avoid the to make sure the distance is enough. This is our echo lab. Yeah, the echo lab. You can see we have screen between operator and also patients. Yeah, this is our counter. We have screen it, and then all the staff use masks, use face shields, and then all the protocol procedures. Yeah, and for elevator also we make a rule that all patients have to make distance, and to go to the elevator, the elevator have to just only several patients can come in one times to make the crowdicity of the lift, the elevators. So it is our screen to protect the doctors and the patients, to make distance of the patient and doctors. This is the situation in elevator. You can see we make a box that the patient and all cannot come to the patients to the lift crowdily. This is the situation of our ICU, Hsieh, and polyclinic outpatient ward. And also in the pantry, yeah, we strictly said to the staff not eat together. If they want to eat during the breaks, they have to make a space like this, yeah, and then don't chit chat too long in the pantry. Okay, this is how we use it. This is we cleanse every times in our place, yeah, like elevator buttons and ICU, and also we use UV. This is the cleanliness of the cleaning procedures, and this is our staff using the procedures. Okay, so to manage our patients, we use our media social and telemedicines to make sure that our patients have the enough information about the disease and can contact our staff regularly, and then to motivate the patient to control his disease, and then if there is a problem, problem within the disease, they have to come to the hospital directly. Don't worry about the disease, because our hospital have all the protocols to prevent the contaminations or the spread of the virus. And about the cath labs, we have the COT-STEMI before. This is COT-STEMI, and then this is the situation before disease. So this is our program of cath labs, COT-STEMI. So we as you mentioned, Professor Hsieh, that we have to consider about this problem, and this COT-STEMI before the pandemic already make a very good result. This is prepared to publish, yeah. Door to balance time, we reduce it. Length of stay, we reduce it. And also, the most important thing is the total cost we reduce during the COT-STEMI. So, the MACE also reduce, and the mortality also reduce. So, this is our local guidelines. All the patients have to do the rapid test, and then if positive, we have to perform the swab test. Yeah, this is our protocol. Is similar with our national or local procedure. And then we try to make the cath lab like this. Yeah, this is, if I'm not mistaken, in Hong Kong. Sorry. So we have to try to make our cath lab. This is the situations during patient COVID-19, doing the procedures. We use the proper PPE, and then we have 3 cath labs. Then we try to make the cath lab 3 as a negative pressure cath lab, so we can use it for all the procedure using cath lab with very use the protocol very tight. So this is the plan to make our cath lab become a negative pressures. So this is our summary. COVID-19 is have a comorbidity. One of the comorbidity of the pre-existing can cause the problem of disease is cardiovascular. But the COVID-19 also can cause the complications. One of them is cardiovascular as well. So both of these problem can cause the critical condition or death. But most important, we have to make sure, we have to ensure the patients have to control the disease. Because cardiovascular disease is the chronic disease, and then they have acute on chronic or acute conditions. So we make sure the patient don't worry or not afraid to seek help, come to the hospital if they have the symptom, have chest pain, difficulty breathing and so on, to come to the hospital to prevent the acute condition. So we have to work together as integrated cardiovascular disease service with the corporate, with the hospital. Together we prevent the disease. I think that's all. My presentations. Cardiovascular disease as a progressive and chronic degenerative disease must still be managed properly, and the acute condition must be treated properly as well. So I hope this slide can make a lot of questions, and then please Professor Hsieh and Professor Wu share how Taiwan can do very good nationwide, yeah, very less patients, and then also in your hospital can do very well in the hospital. And then I want to learn more to your center. That's all my presentations. Thank you so much. And I'm very sorry for inconvenience because of the connection is not stable. That's all. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you. Thank you for your nice talk. Could you hear me?
Yes, we can hear you, Prof.
Yes.
Clearly, Prof.
Is there any problem from our friends in Indonesia?
Tuh, dia ada pertanyaan nggak?
Now is the time for Q&A. Is there any problems from our friends in Indonesia?
Yes.
There is a question already.
There's some question from here. This question for Dr. Hsieh. In NTUH, did you set your cath lab into negative pressure room, or do you have separate cath lab for patient with COVID-19? That's first question. And second question, how do you screen the COVID-19 status of patients that are going to get treatment in cath lab? Do you require PCR testing for all the patient who need a primary PCI? There's two questions. Maybe you can answer immediately. Thank you.
Thank you. Thank you for bringing these questions. For the first question, actually, we haven't yet set up my cath lab into a negative pressure room because we don't have enough funds. So instead, we followed our national screening program protocols. So every patient, if they are asymptomatic, no fever, no upper airway symptom, for elective cath procedures, we don't have to have them receive any PCR testing. But if they got fever, then we will stratify their risk. If they have fever or upper respiratory tract, we will contact our infection specialist for possible isolation identification. So if they don't have urgent cough, we will contact our infection controlled doctors first. In the future, maybe I have seen that in Cito, we have one negative room cath lab. I really want to learn how much time you spend to make one room become negative pressure. Thank you.
Okay. Professor Hsieh, actually in our center in Rumah Sakit Cipto Hospital or in PJT, Integrated Cardiovascular Centers, have not yet have negative pressures, but we are now doing it. We plan to do it, and then now as stage of planning stage, and hopefully by next 2 months we can start to develop our negative pressures rooms. So currently we only use cath lab 3. Cath lab 3 positions is a bit spread from cath lab 1 and cath lab 2, so we can make sure that there is no contamination between cath lab 3 to the other ones. So, and then also we have to modify our cath lab 3 to the in and out positions, yeah, and the cleans and not cleans patients. So we have to make the procedures with. We have to modify the procedures same as your centers. So we don't have it, but we plan to do it. So we hope next month or next 2 months we have it negative pressures cath lab. Thank you, Professor Hsieh.
Thank you. Thank you for sharing. And here we have some questions for Dr. Ginanjar. And please see the slide. Slide. Could you give us the Dr. Hsieh slide at the end?
Dr. Hsieh slide.
Ada pertanyaan dari sana kayaknya.
Iya. Mau share slide, Dok.
Okay, could you see the slide?
Yeah, we can see the slide.
Yes. The first question is, could you share your experience in the COVID-19 related cardio environment? Because in Taiwan, we have very rare case of documented COVID-19. How do you evaluate and manage this patient with cardio environment? Thank you.
Okay, thank you, Professor Wu. This is very difficult to answer, but I just want to share our experience. We are, as a general hospital, we are not in the first phase of this pandemic. Our hospital is not as a COVID referral hospital, but we prepare it. We have built the place that we can isolate the patients. We can separate the patients, COVID and non-COVID patient. But our emergency rooms is still only one room. So patients come to the hospital with a lot of symptoms. And for the cardiac problem, the symptoms is sometimes is similar with the COVID-19 patient, especially if patient come with difficulty in breathing. Yeah, these new patients. So we have experience. Several patients come with chest discomforts, come to this new patient, difficulty in breathing, comes to ER, and then in the ER we have to reanamnesis the patient. So the triage is very important in these conditions. So patient, our staff do the triage. They ask how about the risk become COVID-19 patients, and also the risk become cardiovascular disease patients. So we have a protocol here, and if the patients have COVID-19 problem, we try to separate the patients. But some patients come with the symptom is not typical, yeah, with only difficulty in breathing. So we have maybe 2 or 3 patients come to our ICU, and then after a while, the next day we know the patient is COVID-19 patient. So it's very difficult if the symptom is not typical, Prof. But if the patient is typical, we spread it in the triage. In the first, they come to the emergency. How about the elective patients? In the polyclinic, in outpatient clinics, we also do the separations patients. All the patients come, we have to do the screening to patients, the temperature screenings, and also the anamnesis. If have contact with patients or come to outside Jakarta and so on, we have separate patient go to Kiara. Kiara is the one specific building for the COVID-19. So we treat the patients in that special building. It's separate from our center. we manage the patient, Prof. So most important is triage and also the screening.
Okay, thank you. And
yes.
Hey, this is the second question. In some countries, the STEMI cases are decreased during the pandemic, and the repetition was made for up to 1 hour, such as in Europe. What's your experience in Indonesia? Is the STEMI cases decreased, and is the repetition therapy the time time prolonged in the pandemic period?
Yes, Prof. Same in Indonesia. The STEMI cases is decreasing. It's decreased during the pandemic. So in March, April, and May, the patient is nearly zero. Only 1 or 2 patients in 1 week. Usually we have one patient, at least 1 or 2 patients in 1 day. But during that early phases of STEMI case of pandemics, we only have 1 or 2 patients in 1 week. So it's nearly 0 patients. So the patients of STEMI decreasing. I don't know, because of they afraid come to the hospital, or because of the STEMI case mimicking or masking with the COVID-19. But in that phase, if patient come to STEMI case, in that phase, we still confused about to separate patients. This is COVID-19 or non-COVID-19 patient. So at that time, we also have a long delay to make a diagnosis is COVID or non-COVID. But after that, May and June, we have established our lab. We have a good better performance to differentiate between patients. Our test also very fast, so we can make sure that patient is COVID or non-COVID. But true, Prof, still have delay. Yeah, our STEMI before this pandemics already can achieve on around 100 or 110 minutes. Yeah, not 90 minutes, but yeah, near 90 minutes. But in pandemic delays, it can cost around 200 or 300 minutes. Yeah, 2 or 3 2 hour and more times needed, because they have to exclude this is COVID or non-COVID. So we use reperfusion therapy with fibrinolytics. So we use fibrinolytic more than primary PCI. So that's our experience, Prof, in our center. That's all. That's my question. My answer. Sorry.
Thank you. Your experience was very different from Taiwan. In Taiwan, yes, elective was decreased also, but the STEMI case was the same before and after the COVID pandemic. But your experience was very similar to that in United States or in Europe. The STEMI case seemed to be decreased, maybe due to the fear of the infection in the hospital.
Okay.
We could proceed to the final question. The final question is, during the pandemic, the total prime time was prolonged in most countries. So do you have a hospital-wide modification of your therapeutic strategies, such as when to use fibrinolytic therapy and when to delay the procedure?
Yes, same in Indonesia, Prof. We delay the elective patients if, especially in first 2 months of pandemics. Our pandemic started and in March. Yeah, our governments have announced the pandemics in Indonesia is March. So March, April, and May, we do a lot of delayed patient because all the patients not go to hospital, afraid to go to hospital, and also we were setting our hospital to prevent the spread of this disease. So we delayed all the elective patients at that times of periods. After May, June, and July, we started to continue our services. Yeah, we can do normal before pandemics. Our cath labs with 3 cath labs, we can do 10 to 15 procedures every day. And during the pandemics, in the first months, March, April, May, is only 1 patient per day. Only 1, maximum 2 patients per day. So we delay all the elective patients. We just do the emergency or urgent patients. But in June and July, we started to increase our numbers, and then now we can do 7 to 10 procedures every day. So for cath labs, and 1 to 2 operations for OT. That's our situations. But for STEMI, agree, Prof. If it is delayed time, we consider use fibrinolytics more than primary PCI. So we do a lot fibrinolytics in this pandemic because of time is muscle, you know. And then, but now we have more a better test and then better system. So started July and first August this month, we can do primary PCIs as a modality to do this manage to STEMI patients. That's all my answer. Maybe you can share your experience. How about in your place, your center?
Okay. In fact, in Taiwan, because the COVID-19 patient was rare, so our total follow time was not delayed. The mean was about 62 minutes, just like before the pandemic. So most patients in Taiwan is still receiving primary PCI.
Okay.
Is there any questions? If no more questions, I'll hand over the chair to Dr. Timatuni for closing. Thank you.
Thank you. Ada pertanyaan mungkin di sana? Nggak ada? Do you still have any questions from Jakarta? Yes.
Dr. Trimartani, maybe I have one question from myself. Can I ask Professor Wu and Professor Hsieh? Yes, please. Yeah. It is not about the hospital, but how Taiwan as a country can win from the pandemic. You said the COVID-19 patients very low. I want to curious. My curiosity to see what you do. What did you do to this situation? Because the Taiwan and the Wuhan is very close, but you can win the pandemic. Please explain to me. What?
I think I'm quite lucky and thankful to our government and control. From the very beginning, maybe in January, our government started the border control with very strict restriction to allow foreigners come to Taiwan, especially passengers from mainland China, including the Wuhan city. And from that month, our social media from the news, we all collaborate very closely with the government to spread the news, to spread the ideas of social distancing. And from then on, our government recruited the factories that manufacturing the masks to combine the industry with the government to provide enough masks for general use. So in Taiwan, I think the first is the government to have border control, to have adequate supply of the masks, and very early restriction of the restaurants, the hospitals, all from the central government. And actually, I think the most important thing of all is that our government follows the suggestions from the expertise, especially from infection doctors. So I think that's three unique features that Taiwan adopted since the outbreak of the COVID-19.
Okay, thank you, Prof. So number one is government, yeah, Prof. So we hope we can follow you.
Next question for Dr. Eka Ginanjar. What kind of PPA level you use in PGT-RSCM in the era of COVID-19 pandemic? And the second question, in PGT-RSCM, do you do PCI indicator lab for suspected or confirmed COVID-19 patient?
Okay, number two, I answer yes, we do the PCI cat labs, but we have to make clear the indications. Is it need to do the PCI agent in cat lab? But if the patients can cause the aerosol, like intubated patients, pediatric patients, we use PPE level 3. That's all my question.
Thank you.
I think the time is up.
We have
Yeah.
maybe enough for the question.
Yeah, I think a lot of questions, but the time's limit, we can close these sessions. Maybe Dr. Trimartani can close the sessions.
I would like to extend my appreciation to the Professor Chih-Cheng Wu, Professor Dr. Mu-Yang Hsieh, Dr. Eka Ginanjar, Miss Yuni, and all the committee that has established this webinar or this session. Apology for the technical problem, but I think overall we could absorb both information, experience, and I think it's a very important sharing moment that I think nobody is experienced the pandemic of COVID yet. So sharing information, sharing knowledge is, I think, a very important phase. And we need a lot of improvement, and also congratulations to your government that has overcome the pandemic stage, and then I think we have to learn more about that from you. And then I think I would like to share our next session. We will be on the 29th of August 2020. Also collaboration with the NTUH-RSCM joining webinar series, the critical care in COVID-19 is and pulmonologist point of view. So there will be a discussion in the ICU and how our pulmonologist colleague handle this COVID-19. So again, I would like to appreciate to all, and I hope everybody can enjoy the rest of the day and spend our Saturday afternoon together with our family. Demikian saya tutup. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Professor Wu. See you again. Hopefully you can come to Taiwan next time. Yeah, come and enjoy with Taiwan.
Visit us. Yeah.
Thank you so much.
For your closing remarks.
Thank you, Miss Yuni.
Terima kasih.
Terima kasih.
要转那个镜头，让不用了，没有关系，大家都还在啊。
again in the next event. Thank you. Good morning. See you later.
See you. Bye-bye.
Masih lihat timnya.
Kita mesti lihat timnya.
Ya, masih lihat timnya. Nih, tim kita.
This is our team as well.
Ya.
Ternyata banyak.
Okay, see you again.
Thank you very much. See you in 2 weeks. See you all in 2 weeks. Bye-bye.
Bye.
好，拜拜。好，我们照相吧。你要坐下来，稍微坐下来。
OK 听吗？
在那个，我把这个。
给大家讲一下啊。